There is a history that those of us in behavioral health care share, a history of pain and of promise, a history of terrible stigma, and a history of enlightened efforts to overcome that stigma. It is a history as old as time, as old as bewilderment itself. The human mind, the human spirit, crushed beneath the weight of illogical thought, damaged emotion, addictive disorder, and public disgrace. But like all history, the story of mental illness and treatment is an evolving story, and thankfully, this story is one full of hope. The role of community mental health care is central. Those community mental health workers who ensure daily nurture, professional leadership, and public support are the foundation on which hope stands and on which success depends. Their devotion, along with marvelous advances in medical science and pharmacology and the involvement of dedicated loved ones, has made it possible for the mentally ill to find their way back from the edge of hopelessness. Our story focuses on that part of mental health care which begins in the 1960s when President John F. Kennedy signed into law the Mental Health Retardation Facilities and Community Mental Health Act.
I've sent to the Congress today a series of proposals to help fight mental illness and mental retardation. These two afflictions have been long neglected. They occur more frequently, affect more people, require more prolonged treatment, cause more individual and family suffering than any other condition in American life. It has been tolerated too long. It has troubled our national conscience, but only as a problem unpleasant to mention, easy to postpone, and despairing of solution. The time has come for a great national effort.
We're very fortunate that we have people who have a wealth of history, who actually have been, in some cases, at the same center they're at now all of their professional lives, have seen those centers develop from the very beginning, and have had to make all the evolutionary changes and all the evolutionary decisions in real time. And now we have an opportunity to capture some of their thinking behind that, some of the history and some of the values that went into some of those tough decisions.
When we started, community mental health meant community mental health for everyone, and that meant people who were poor, and it meant people who had average amount of resources. It meant people who were uneducated and people who were educated. But gradually over time, probably as a result of funding and other changes, I've seen a lot of mental health centers become organizations that serve especially chronically mentally ill individuals in their community. And yes, they still focus on the community for those people, but I think the larger vision, the provider for the whole community, the organization that can reach into people's retirement years, young adult years, families, that's changed for a lot of organizations, and I regret that.
It was the first time in this country that we had a public policy about mental health. In order for states to receive funding for mental health centers under this legislation, a mental health center had to agree to provide 5 basic services: outpatient, inpatient, partial hospitalization services, 24-hour emergency services, and prevention, consultation, and education.
There was a lot of excitement generated, a lot of creative thinking, a lot of very bright people from universities across the country, and a lot of very bright young people who wanted to do good, to help people in their lives, were gravitated toward this community mental health center movement.
I was a chemistry major in college, and I got a job as an orderly on a psychiatric unit.
I was asked to participate in the ECT team, electroconvulsion therapy team, and in that role I was required to hold a rubber mouthpiece which depressed the tongue and assure that the airway was open, and support the person's neck right behind their head. And a physician, psychiatrist in training, would take 2 electrodes and place them one on each side of the temple. And then we had 2 aides standing on each side of a stretcher holding a sheet up, and the patient laid on the stretcher with a sandbag under their back. We would induce grand mal seizures.
Back then we were doing electroconvulsive therapy and doing Thorazine was still relatively new. Stelazine just hit the market, but it was still, and that was state-of-the-art treatment. So we were doing some pretty, what we thought was pretty innovative and creative things even then.
And I was assigned as the social worker on the unit, and I walked on with my keys and opened the door and walked in, and here were all these men lined up in a day room, and there was a TV on in the corner of the room. So I walked in and walked across the room, and I reached up and turned the television off. The thing that struck me was not one thing happened. I turned the TV off, and not one thing happened. Nobody even looked up. Nobody said, "What are you doing here? Who are you? What gives you the right to come in and turn our TV on or off?" Or "I was looking at that." They all just sat there. And I thought, you know, at that moment, if that's what institutionalization does, then we've got to do something different.
I read Gerald Kaplan's book, Principles of Community Psychiatry, and the word community jumped out at me, the methodology jumped out at me, and I knew that I wanted to be involved in community mental health.
Idealistic and talented men and women had chosen to enter the field of behavioral health care. They would be challenged by an innovative but minimally funded program, which would require their most creative efforts to fulfill a nation's dream.
We were operating in places that...
church basements
yes,
and condemned buildings.
That's right.
It was probably a two-staff agency with one secretary and a board of directors, and I think we were at about $35,000 at that time, most of which was from the United Way. We didn't even really charge fees in any real sense of the word. People would give a little donation.
I started off with a $50,000 check from the mayor of Providence with a 9-member board, and that was it. And we had nothing else. And wrote a grant and received city-state matching dollars, and opened our doors with four people, of psychiatrists 4 hours a week, and a psychologist, an assistant, and myself.
Moved to as a CEO of a small, very small mental health clinic, actually, at that time, where a total of 5 staff, including the secretary bookkeeper.
The first mental health center that I was in Louisville was in a abandoned TB sanitarium. The building was condemned, and the first staff member that I had that retired gave the center a roach motel as a going away gift because the roaches were big enough to move the furniture around.
It was a very much a mom and pop type shop at that point. In those days, for example, we didn't know what a clinical record or a medical record really was. People wrote notes on the back of an envelope and put it into a file folder.
When we opened our doors, people began to come to us, and as we received more money, we got more response, more people wanted it. It just grew and grew, and what was exciting about it is it just started at scratch. You know, it was started from scratch.
With federal government construction and staffing grants in place, these emerging leaders could now respond to the very real needs of their communities. Those who came through their doors seeking help were the face of an entire society. The core values of service and inclusion held by these early leaders would be central to the evolving movement.
We took very seriously a lot of notions. One that I remember very vividly was a responsibility from cradle to grave, so that we had a catchment area or a defined population, and we were responsible for their mental health from the time they were born until the time they died. And that was a brand new concept.
I saw the value of the 5 essential services coming into play, the value of being able to work with individuals through a team approach. And that's where I got very excited.
We were very idealistic, and a lot of us were getting into this business because of that idealism. And I think that it was based on the old public health model that was really important to us, that we were going to make a difference in our communities, and that and so we were very mission-driven and vision-oriented, and the economics of the business took a back seat actually to a lot of what we did. I mean, we were always prepared to do more with less.
There were really a variety of simultaneous movements going on that I think were co-occurring with the community mental health movement. I mean, there was the civil rights movement, there was the women's movement, there was the student kind of counterculture movement. I mean, all that stuff's kind of happening simultaneously.
It was embedded in the culture of the 60s. And so the values that were predominant then really permeated the community mental health movement. So that was one thing. There was a great deal of idealism. You didn't use the word this was a business, it was a mission, a purpose. And you made use of what was there.
All the states were required to come up with a plan for the delivery of mental health services in their state. Most states then adopted to let the provider community apply for what was called construction grants or staffing grants, and the money went directly to them and not to the local government. So we were accountable to the federal bureaucracy. I recall the regional offices of the National Institutes of Mental Health would come out and do their site visits. And we were really being driven by federal policy, which put us above local politics.
Federal funding, construction, staffing, and conversion were basically capacity building by the feds. It was like, let there be community mental health.
$50,000 planning grants to each state to find out how many people were mentally ill in the state, what resources were available, and come up with a plan as to what you're going to do in your state. Now imagine that. I mean, that's in the 60s. That's over 40 years ago, when even the states had no understanding of the degree of mental illness that existed in their states or how many the resources were.
And it was interesting. We got it, as most centers did, I think, back then, through a partnership with our local hospital, because one of the 5 required services was inpatient. And so we had to enter into a partnership, in our case with Halifax Hospital, so that we could have all 5 of those pieces in place. I think the other thing that was unique in our case, and probably most cases, is that you had to match that staffing and construction grant with local money. And we had never, back when this occurred back in the 60s, in Volusia County, there had never been a major fundraising campaign for anything. And it was amazing how the community came together to raise $150,000, which was an unheard of amount of money back then, and not only met that fundraising goal but exceeded it, because people got excited about having affordable mental health services right there in the community.
In 1976, there was additional federal legislation which provided money to add services. These specialized services were aftercare, were transitional services, children, adolescents, elderly, services to alcohol clients, to drug abuse clients, and then the pre-screening.
An exciting new movement had begun. Our nation was waking up to the realities of mental illness and related human need. This heightened awareness resulted in growing expectations for effective solutions.
In the years 1970 to 1980, the largest number of Supreme Court cases in any class were mental health. We, for years, have characterized the deinstitutionalization of state hospitals and the development of community mental health centers as an economic movement on behalf of the states trying to save money. In fact, it was a civil rights movement. It was, these people have rights, they have, quote, least restrictive alternative, which really became a watchword in community mental health much after the development of the initial thoughts. And it came out of the law. The notion of the right to treatment or the right to refuse treatment. All of these cases, starting with Wyatt versus Stickney, were all cases that, interestingly enough, were in large part also financed by the federal government.
And then in the early 1980s, the block grant legislation was passed. And this is very important to keep in mind and to remember, because it really altered the landscape of the way we were practicing at that time. It significantly restricted the ability to continue the vision of the community mental health system as it was enacted. Basically what happened was the dollars that used to go directly from the federal government to the community mental health center in the local community was diverted to the states. And what happened was that the dollars that were going were basically rolled together into one lump sum. And before they were allocated to the states, they were reduced by 25%, about 20, give or take a little bit. And then they were allocated to the states, and said, and the federal government then said to the states, you run the system and you provide the funding.
The notion was that you were to be replacing those funds from patient consumer fees, insurances, or from other community funds, the United Way or local funds of any kind. That was the master plan, but we found it very difficult to replace those funds as we lost the staffing money. And particularly in the low-income communities and in inner cities where there just wasn't the revenue base there.
And I do remember a couple of years, because when I first took over, I said, well, if I will get going, and the first call I got was from Florida Power and Light that said, are you going to be able to pay your light bill this month? And we prefer you bring down either a cashier's check or cash, because your last three had bounced. Now I know why everybody left and I got the job. But you know, the good thing was we pulled the community back together and we sat down and said, hey, the idea was this was to be a partnership from the beginning, and as they phased down, we were supposed to be building up. We didn't do that. We sat there and like, the feds will come up with something or the state will come up with something. And a lot of centers went under or had to merge because they just didn't prepare. We went on like a 2-year deal and unfortunately did some layoffs. The hardest thing I ever had to do was go around and lay off really qualified therapists because we couldn't afford them. But what we started doing was going on a track of this is a great business to be in. We can take care of lots of people, but it's got to be run like a business. And we started putting some business people on the board that had a caring heart. We started involving a lot of other people.
I was one of the ones hired when the state started picking up after our federal staffing grant had run out, and we had a devastating loss of employees when that federal grant ran out because the state wasn't prepared to pick it up in 75. But in 76, some state money started rolling in, and I was among the first wave of folks that were hired when the state began picking up that loss of federal funds.
Well, at the same time, in most states, again, the deinstitutionalization process was taking place. Folks who were in the state hospitals were being discharged to the local communities. Well, that was happening without additional state funding. The legislators were not allocating new monies, and they weren't taking the monies out of the state hospitals and sending them to the communities with the patients, coming back to the communities. So the states were faced with this new responsibility of new people coming out of the state hospitals into the communities and no money except, the block grants. So basically what the states did is they took the block grant monies and they commingled it with other state funds and they provided it to all the providers, whether they were previously federally funded or not.
I believe that's where we began to see the difference in terms of community mental health centers being able to comprehensively deal with communities like we used to.
So for the community mental health center to continue to provide the services, they all of a sudden at one time had less dollars. Not only were there less dollars, but the states were in a position too to begin to really restrict the use of these funds. And in most part, the states told the providers, you must use these funds for the severely mentally ill. A very deserving population and a very needy population, but it restricted severely the center's ability to continue to provide the services they were originally set up to provide.
I suspect that there are industries out there that have funding as complicated as ours, but it's hard to imagine. I mean, because every one of our various funding sources, and we have maybe 20 or 25 different funding sources, and every one of them has a different set of rules as it relates to how the money is to be drawn down. And in some instances, it's to be drawn down specifically for an act or an activity. In other instances, it's to be drawn down if you're doing good things. And how to put that all together, and then how to communicate that to your staff so that there's a clear message out there for them that if I'm this kind of a person with this kind of an eligibility, I get these set of services. If I'm this kind of a person with these kind of eligibilities, I don't get those kind of services. And that, I think, is very, very hard and very, very difficult to communicate to the staff, people who are out there in the trenches day in and day out.
Yeah, that was the one period of time where we could legitimately do community education because we were expected to do it and we had some financing to do it. Once that federal money kind of pulled away, nobody is in a position or interested in helping us do community education. That was one of the things that was really important in the early period, was to provide educational programs, to go into the schools and other kinds of places and do C&E service. Nobody pays for that today.
Not depending on the government and depending more on yourself is where we've had to go. We're into management and technology that 10 years ago I'd have said, you're nuts, we wouldn't be into that.
We were the spiritual, emotional, creative leaders of our organizations. No, we really were. You know, they looked to us to come up with the ideas, to champion ideas, to stretch the boundaries, move programs out into the community, take advantage of partnerships. And then as the money got tighter, we found that we had to start paying much more attention to the basic business of running the business. So we had to be more concerned that our money was put in sweep accounts at nights. You know, we didn't know what a sweep account was, you know, but we found that we had to make interest on that money every night because money was short. We had to learn to manage our investments and look at whether or not to buy real property or lease it. That became a major issue. How much property should you own in your portfolio? You had to learn to manage your health care benefits for your employees, and what was a reasonable amount of them to contribute to the health care plan, or should you provide all their benefits for them? And all of these issues became major focal points. And for many of our clinicians and many of the people that got into the mental health center movement in the beginning, they felt that we were becoming much too much business oriented, that we were losing our initial tenets of community mental health, and that all we cared about was the business and the dollar. They didn't realize that if we didn't care about the business and the dollar, they weren't going to have a job. But somehow that never really, they weren't able to make that connection.
And so we have had to make that shift from being creators to bureaucrats, from creators to business, and not business as usual. And it just puts a whole different perspective in my mind on what it is you're doing. And I find myself nearing the end of my career kind of saying, you know, I created this thing. Now what I'm doing is trying to save it.
The managed care movement, with an additional tightening of resources, forced us to be even tougher managers.
Managed care has tremendous opportunities and advantages for the community mental health movement and the chronically mentally ill if done right. If in fact you can take high-cost services and put in place wraparound programs in the community, build skills within the clientele in terms of work skills and housing skills and social skills, and help prevent them from being in a hospital. I mean, the reason people end up in hospitals is because their housing situation has failed or their medication is failing. Well, if you can try to deal with those very things and use the Medicaid money that would normally be paid on a fee-for-service model to do that, then so much to the advantage.
And in fact, I think managed care companies on the commercial side are turning more and more to community mental health centers to help them find ways to do good managed care in the behavioral health area. I know that's been my experience. I think they're struggling with their systems more than their philosophy around treating people. Yeah, I guess we can look with a jaundiced eye, those for-profit managed care companies that are looking at the bottom line.
I do not always chase an available dollar. And that has to do with really taking a look at your mission and really taking a look at your values and taking a look at what you do well, as opposed to doing everything and maybe some of it isn't going to be done as well. Now, this is a hard lesson for all of us, and I think it is something that I've learned the hard way also. But we now basically, management-wise, have an ongoing grid where we look at dollars that are coming available, and there's always some dollars through the legislature available. In the past, I think many of us would chase whatever dollar was available and say, well, we'll figure it out once we get the dollar. We don't do that anymore. I think we're much more focused on what are we good at? What do we do good at? at and pursue that, as opposed to saying, well, we don't do adolescent substance abuse, but there's some money coming down, and let's get into it.
But when you're faced with, at least when one of our child psychiatrists is taking care of trying to medicate 12 autistic children, you know, and so he says, what am I supposed to do? Stop seeing them? And our board and I said, no, we'll find some money somewhere to do this because these kids need to be seen.
It became obvious to us that if you eliminated essential drug and alcohol services and emergency services and said we can't afford to do it, the impact on the rest of the system from a cost basis would have been far greater because the overload of demand through other channels. Now, people seek the channels that they're comfortable with and they're available. If they're cut off, they're going to go through a different channel.
It's getting harder and harder to find some place to cost shift these things to. That's the bad news. The good news is with an organization like MHCA, people have good ideas for new markets, creative ways of going after new funding and new populations.
As the financing changed and almost the vision, if you will, or lack of vision, if you will, of the financiers, the governments, changed with each change in bureaucrats. It was never quite clear what we were intended to do.
Despite funding stream changes, despite regulatory changes, I find myself unable to give up the piece that the mission that our organization and other organizations were designed to serve the whole community. And my attitude became, if the government won't pay for this, then who will? I know it's valued, I know it's making a difference. What other ways are there to get these services paid for, to get this service delivered to the people who need it or want it? And I think that's where the emphasis on becoming more entrepreneurial came from in our particular area. I wanted those services to be maintained, I wanted those people to be served, and I wanted to continue to make a difference in the community.
So we didn't care about the community mental health value system. It would be just as easy to downsize the organization and do whatever the money would pay for and say, the heck with the rest of it. But that's what drives it, I think, is that we really believe in that mission. And so our job as managers, as senior managers, is to find funding to help make it happen. That's the challenge.
The concept and vision of the Community Mental Health Center was basically abandoned by the major funders and policymakers in the early 80s, and for good reason. They had issues they needed to deal with. But the lack of funding made it very difficult to continue that mission. But in spite of that, some centers found a way to continue to provide those needed services to their communities. And that's one of the major reasons that MHCA was founded. The early founders hoped that by pooling talents and resources of the members, that together they could find ways to provide those needed services to the people of their communities. And I'm proud that MHCA was part of that.
One of the things that kind of worries me a little bit about this is that, and that's part of the reason why we're doing this tape, is that our successors will not have the benefit of having gone through what we went through and seeing the changes and what the original motivations and values were of community mental health. I'm training my managers, my senior and middle managers, to think in terms of business. And so they're one generation removed from all of the stuff that we've been talking about. And that's kind of that can be a concern. I mean, they're going to take for granted that this is a business, whereas all of us had to adjust to that idea and either make it or break it. I think there are a lot of folks who started out in this business who couldn't make the change, as Gary mentioned, from that leader and visionary to the business person and running the thing like a business.
So with people today in some circles are saying that the community mental health centers have failed or they didn't live up to their promises, but that's not true. The original mission and vision worked. It really did. It was a great concept.
And we still have the original statement from John Kennedy about what a community mental health center was supposed to be, and we each year benchmark and see, are we still doing that? It gets harder, but that's our goal, and that's what we try to do.
Pick your business-oriented people very carefully. Look to their values and their value system and make sure that they share a value system with your clinical staff to the extent that they can, and also be sure to keep educating your clinicians to the value added that a good management staff brings and a good administrative physical staff brings.
Human needs don't disappear. So consequently, the world may change around you, funding sources may change, but you'll always find opportunities because those basic human needs that you're addressing in your business are there. And consequently, if you can recognize that and address that, then you'll continue to be successful.
And we do try to hire business people who care about our mission. They may not really know and understand it the way a clinician would, but they certainly care about it.
All of us started as clinicians, and I don't think any of us has ever lost that fundamental desire to help people that got us into this field, and it goes hand in hand with our sense of mission as an organization. But I think that's one of the things that's unique about our industry is you've got CEOs who have learned how to do the business end of things, but I don't think any of us ever lost what brought us into this business in the first place, which was the desire to help.
We've seen the building of the centers, the different changes in financing, and I'm beginning to wonder, is this the end of a business cycle? Or is this the beginning of a new phase? I'm hoping it's the latter, but I lack the vision to see that right now. And I guess for the colleagues that are going to come behind me, I hope they have that vision. And secondly, I hope they have the passion.
But when I do the orientation, and I do the orientation for all our new employees, I said, you don't ever need to worry where your paycheck's coming from. If there's a problem, we'll let you know. What we're hiring you to do is provide service. You're the most important person you'll see every day, whether you're the housekeeper or whether you're the doctor, is our client and their family, and whatever they want, you smile. Unlike Sears, we don't sell widgets and vacuum cleaners. All we got to sell is caring, treatment, and support. If you can't do that, get out now.
How do you marshal around you those kind of personalities who also believe as you do? And that is that's the fear that I have as things move along here and as other come into the industry. Do they have that same kind of grounding that so many of us had in terms of that's like a burning issue? I mean, it's like you can't not do that because that's what you're all about. You're all about making sure that people who don't have services have services available to them.
Find some way to fund the kind of services that are necessary if you're the best organization, best position to do that, and just to be open, to be very, very open to the opportunities that exist to help people meet life's challenges.
Pay attention to and stay on top of what basic human needs are. Folks need food, we need shelter. I need a group of folks to love them, I need to be loved and to love, and I think that in me starts to get to defining what a real community is. I think we need to stay in touch with those basic human needs. Regardless of what the media tells you, you ought to have to be worth something.
And the movement really is that we're about providing services to the people who are the sickest and who are without resources. And I think if you kind of continue to see that in everything we do, the business decisions we make, the entrepreneurial activities, the way we go out and try to generate money, it's all to underwrite care for people who are the sickest in our community in terms of their mental health needs and those who basically don't have any resources.
We need to pay attention to the distinction between what humans need and what our culture will tell you you ought to be about and what humans need. I think you have to pay close attention to both of those because that's where a lot of folks get stuck. And that's where a lot of, and that drives a lot of folks crazy. And so I think those are the issues that we need to pay very close attention to and know where your own heart and mind is with those issues, what humans need to thrive and survive, and what our system provides and how at times those conflict with each other. So how do you work through that interface? How do you work through those conflicts?
This is a person, this is John, or this is Mary, or whoever, and what does John need that I can help a while until John gets on his way or Mary does this, and not paternalistically, but just people go through life crises, and be there to help them move on and realize as much as possible in their lives.
Caring and compassion, and seeing them as an individual, whatever their needs may be, not compartmentalizing and saying he's alcoholic or he's schizophrenic or whatever. If he needs food to start with, provide some food for him, and carrying it right on through after that.
There are a lot of people who have a lot of heart who selected to enter into helping professions from some other avenue and have just as much capability of continuing what we've been doing as I think as clinicians do, as long as they got the heart and the desire to do it.
Passion and the drive to do good, to really take care of people, to support them in the community, is the glue that puts it together.
That fire has to be burning, and it has to continue to burn. And the challenge, I think you innately have to be competitive. The challenge of what you're going to face is not a challenge that can deter you, because if you're deterred by it, you're moving away from your commitment to the mission. You have to have the fight to stay in it.
What humans need is respect, and they need to be treated with dignity. And sometimes the mentally ill do not get respect, and they're not treated with dignity. And a lot of our social policies do not treat them in dignified ways, nor in respectful ways. And so I guess my advice to somebody coming into the profession is that you have to really ask yourself and look yourself in the mirror and say, do I respect people who are different from me? Can I accept them for who and what they are? And regardless of their personal situation, can I treat them with ultimate sense of dignity? And if the answer to those is yes, then you're in the right job if you got a lot of energy.
You need to be able to look inside yourself before you make the decision at your spiritual values, your commitment to what you're doing and why you're making that commitment. It's a lifestyle.
We don't take the attitude anymore that these people need to be cared for. They just need opportunities, and it's really great to see people with very serious forms of mental illness going to school, going to work, having their own apartment. I mean, it's just a really heartening thing to see that having evolved from where we were when we started.
And as I listen to some of the challenges that we've dealt with and how we've been successful in meeting those challenges, I'm sort of tempted to reflect back and say, hey, this movement worked. It made a difference.
I went in to get my cup of coffee in the morning at one of these, gas stations that also serves everything else, and I happened to have my logo jacket on from the center, and I walked up to and I paid, and she said, "Oh, you work for Circles of Care?" And I said, "Yes." And she said, "Oh," and I just like, "Uh-oh." And she said, she reached over, she grabbed my hand, and says, "Thank you. I would not be alive today if I hadn't had your services." And she had a tear in her eye, and so did I. I don't know her name, don't know what. I know she's been working there now for about 6 months, but I can take that to my grave, because that's what it's all about. I don't need to know what she had or was a problem. I just need to know that agency took care of whatever it was. And that's the legacy we don't want to lose, wherever they are. That's where we want to go.